So, hi everybody. Hi. So I will talk about the different clinical entity that we can meet when we assess patient with disorder of consciousness. I will talk about also the difficulty to diagnose this patient and the tool that we can use for decrease this difficulty. So I will first introduce you, even if I know that you surely know every state. I will do it again. So when you assess behaviorally a patient with disorder of consciousness, you assess mainly two components: the arousal level of this patient, but also the awareness of this patient. Usually, when you are like you have a preserved arousal level, I hope so, and a preserved awareness. When the patient is in a coma, there is no arousal and there is no awareness of the environment or of themselves, which means that they have eye closed usually and they show no oriented behavioral response to stimulation or spontaneously. Now, after this patient can evolve after several weeks, and often after several weeks, they evolve to a vegetative state where the arousal level is preserved, which means that there is a eyes opening spontaneously or following some stimulation. But there is no signs of awareness. They are not able to interact with their environment. Now, when they evolve to they can evolve to a minimally conscious state, which was defined really recently by the Aspen Work Group in 2002. There is a preservation of the arousal level, but these patients are also able to show fluctuating but reproducible signs of consciousness, such as visual fixation, visual pursuit, response to verbal order. But even if this patient can show this response, it's still very fluctuating. They cannot, for instance, communicate functionally with their environment. And finally, I will also talk a little bit about the locked-in syndrome. So the locked-in syndrome is not a disorder of consciousness. This patient has a preserved arousal and a preserved awareness. But these patients are tetraplegic and they are not able to speak. So usually it's very difficult to disentangle this state from the vegetative states because they are just motor, they have just a very difficulty to move. So usually, it appears that this patient look like a vegetative state, but it's not a vegetative state. I will talk about it maybe longer. So the problem is, though, so you see there is different clinical entities, but the problem is that this patient can often be misdiagnosed, particularly when you try to detect signs of consciousness in this patient, because of fluctuation in the vigilance, because of motor disabilities. All these factors lead to a misdiagnosis. And recently, we decided to assess this misdiagnosis rate in assessing 103 post-comatose patients. Among these patients, there were 44 patients who were diagnosed as being in a vegetative state by the clinical staff. But in fact, there were 41 patients who were conscious and show signs of consciousness. The more often the sign was the more missed was the visual pursuit. So it's very important to underline the fact that the signs of consciousness are very difficult to detect, and we need some tools for detecting signs of consciousness in this patient. So why it's so important? And we could say, I mean, you know, you treat in the same way a non-conscious patient and a conscious patient. But you know that it's not true, because there is also the end-of-life decision. There is pain treatment. There is a lot of things who interfere with the treatment of patients. And why it's important? Because, for instance, the outcome of VS and MCS patients are different. You maybe know, because there were a study about GENET to show that non-traumatic versus traumatic vegetative patient, there were a difference in the outcome, that the outcome of traumatic patient was better than non-traumatic. But we decided to reproduce this study, but also to show what was the outcome for the MCS patients. You see here, we took the outcome of traumatic, so it's vegetative patient, 52 traumatic. There is the percentage of patient with the outcome of the patient. Red is vegetative states, black is dead, blue is MCS, and green, which is interesting for us, is emerging from disorder of consciousness, more exactly emerging from MCS. So we assess this outcome at 1 month, 3 months, 6 months, and 12 months. And when you compare the vegetative states to the traumatic vegetative states to the non-traumatic vegetative states, you see the green, so the percentage of patients who emerged after 1 year is really more important for traumatic patient versus non-traumatic patient. This is, I mean, is interesting, but we already knew that. Now what is interesting is to see what's happening in minimally conscious states. So you see for traumatic minimally conscious states, there is a more better outcome than for VS traumatic patient. This is also the case for non-traumatic. Even if it's less important, there is still more patients in minimally conscious who recover well after 1 year. Which mean what? Which mean that if you miss some sign of consciousness in patient, you could miss also a good outcome. And you could also miss, so often the outcome permit to discuss end-of-life decision. So it's very important not to miss signs of consciousness. So for this, there were some standardized behavioral tool was developed for detecting signs of consciousness in patients. And one of the most interesting is the Coma Recovery Scale Revised, which was developed by Giacchino and co-worker, which integrated the signs of consciousness, the diagnosis criteria of minimally conscious states of the Aspen work group, and which constituted a very interesting tool for disentangling vegetative from minimally conscious patients. So we decided to validate this scale in French, as it's very important to have this in Belgium. For us, it was important. So we decided to assess inter-reader agreements. We just decided to develop a DVD. So we decided to make some learning about how to, assess patients with the CRSR, and we show exactly what was the different level of consciousness, how to administer the different subscale of the CRSR, and finally we proposed several exercises where they have to score what they saw according to their training before. And so according to that, we had 24 participants, and the reliability of the total score of the CRSR was really high, as it was at 0.80 since the Cohen's-Kappa statistic analysis. We decided also to see if really the CRSR was an interesting tool for detecting MCS patients more than other tools which are used. We compared the CRSR to the Glasgow Coma Scale, GCS, the 4 that you maybe know, These two scales are more used in the intensive care. And the WIM, which is more used in the chronic stage, the Wessex and injury matrix. And what we found is that the CRSR detects significantly more patients in minimally conscious states than other scales. So this is a very interesting result showing that the CRSR is really sensitive for MCS patients. Another thing was to see which one of these subscales is the more sensitive. And we showed that it was the visual subscale. So it's very interesting because I told you that the misdiagnosis was often occurred, for visual pursuit and oriented movement. So it showed that this scale is very sensitive to detect visual pursuit and visual fixation. So it's also an interesting tool for that reason. And another thing which was interesting to show, it's a work I didn't do this work, I was just collaborate on this work. It was the work of my colleague Audrey van Oudenhuis. She showed that according to the item that you use, you have a higher or lower probability to show visual pursuit. So if you use a moving person, if you use an object, if you use the mirror, which is used in this CRSR, you can have different probability to observe visual pursuit. And what we obtain is a really significant higher percentage of patients where visual pursuit were detecting using the mirror as compared to the person, moving person, or as compared to the object. So this also is an interesting particularity of the CRSR and permit to detect these signs of consciousness. Now I wanted also to talk to you about, it's true that we have different scale for assessing the level of consciousness, but there is also a frequent question from the family, which is my brother, is my sister, is my mother in pain? And this is an important question that we have also to respond. But there is no real scale which was developed to detect or to assess pain in this patient. So we decided to develop a tool for assessing pain in disorder of consciousness. We developed the Coma pain scale. In this scale, it assesses the facial expression, the verbal response, the motor response, and the visual response in the patient in response to a painful stimulation. And the total score is 12. So we decided to use the more interesting behavior that we can observe in a non-communicative patient. For instance, there were some guidelines for the elderly people, so assessing pain in non-communicative elderly people, but also newborn. And what they used usually is the facial expression, so the grimaces, the verbalization of the patient, but also the position of the body. And we try to make a scale with all these indications. We try to validate it, and so there is some other scale that we used, which is commonly used for newborn or elderly, and we found a very good concurrent validity. How we did that? We assess in this, I think it was 17 patients, something like that. This patient was assessed with 5 scales, so the Coma pain scale, the NIPS, the FLAC, the CNPA, and the pain ADS, and following a stimulation which is often used in neurology and intensive care unit, which is the pressure of the finger. We did that at the left and the right hand, and we take 10 seconds for recording the response on each behavioral scale presented in a randomized order. We found a very good concurrent validity between the scale. So it seems that this Coma pain scale can assess in the same ways and other scale for assessing pain in non-communicative patient. She acts the same way. Another thing which was interesting is to show that, in fact, the total score obtained by the conscious patient and the vegetative patient was significantly different according to the CPS, and was not different according to the other scale. So this is also interesting because it seems that the Coma pain scale is a sensitive scale for disorder of consciousness. And it's relatively, it makes sense that the score is higher in MCS as compared to VS. I will explain that maybe later with nociceptive stimulation that we used in disorder of consciousness. And finally, it was our more recent finding. We try to establish different level for pain, and we used the CNPA, which had some threshold for no pain, slight pain, and moderate pain. And so we were able to just have some score level, score threshold, to say if there is no pain, slight pain, or moderate pain. And it's interesting to observe that no patient in vegetative states obtain a score underlying moderate pain. So it's interesting also at that point. So now that we have seen that it's possible to have sensitive behavioral tool, that it's also possible to assess maybe pain. It's the first step, in disorder of consciousness. There is also this patient who are not able to respond in the usual way for neuropsychological testing. They cannot give a motor response or a verbal response. So these patients, the locked-in patient more exactly, are very difficult to assess with usual neuropsychological testing. So just for giving some definition of the locked-in syndrome, this patient usually have basilar thrombosis, which affects the ventral pons, ventropontine lesion. It's a ventropontine lesion. This patient, as I told you, can open their eyes. They are, however, quadriplegic. They cannot speak, but they can communicate with their eyes. Usually they communicate with blink or with movement of the eyes. But they have preserved consciousness, and in the diagnosis criteria of 95, is the ACRM criteria, they said that this patient presented intact cognitive functioning. But this was based on very little literature on this subject. So we decided to maybe make a very big neuropsychological testing adapted to this patient. So we developed a cognitive testing based only on ocular response, and we assessed the short-term memory with the digit span, the long adapted to this patient, the long-term memory with the backward span, the sustained attention with I don't know if you are familiarized with this TEA. TEA, Zimmerman. Yeah, thank you. Exactly, adapted for this patient. Executive functioning with the Wisconsin card sorting test, which is not the best one, I know, but it was only the first step for this patient. The language with the lexis and the verbal intelligence. We assessed 10 chronic LIS patients using this method, and we matched we established some normative data with 40 controls, and these controls had only to respond with their eyes. So like that, it was possible to match the performance of patient to the control subject. We just observed what? We observed that patient with only a brainstem lesion didn't have any cognitive deficits. However, we showed that in patients with additional lesion, such as a thalamic, such as frontal or parietal lesion, there were some trouble linked to their area, to the affected area. We also showed in a patient longitudinally, this patient was assessed, and we showed that it's true that in the acute stage, more in the acute phase, there is some maybe deficit in this patient, but these deficits tend to disappear with time. So we observed in this patient a sustained attention deficit at 2 months, but this deficit disappeared at 6 months and 16 months. Why it's important to assess patients at a cognitive level? Because it permits to establish some cognitive therapy for helping them to use some higher level communication, and they need that. They need to be able to use complex technology for communication, and also to communicate their feeling through book or other way to communicate. And also because this patient have a life, a high life expectancy. Sometimes it's not rare to observe a patient living more than 10 years. So it's very important for them to have a good quality of life. And talking about quality of life, you'd be surprised to observe that this patient we assess it's the work of Marie-Aurélie Bruno. So Miss Bruno is maybe easier. And she assessed 65 locked-in syndrome on this scale, the ACSA scale, assessing the quality of life of this patient. And she compared to 820 control subjects. And she didn't obtain a significant difference between the both group. So it seems that this patient has a relatively same quality of life than us, which has to be, you have to be careful with this result, because a case is not another case. So every time it's just for saying that you have not to have an a priori, so you don't have to see the patient and say, oh my God, he's in a locked-in syndrome, it's very bad. I mean, I couldn't live like that, and I think that it's maybe better that, you know, maybe we have to discuss about some treatment or something. So this is not a thing to do. Maybe he will, in his mind, have a good quality of life. So this has to be taken in account, even if a case is not another case. So it's true that mainly the diagnosis is based on behavioral signs of consciousness, but there is also additional information that you can, bring with other technologies, such as the functional imaging. So, for instance, what you see here is the brain of comatose patients. Here, the patient in vegetative states, patient after recovery, and locked-in patient. You see that comatose and vegetative patients have a large network with an hypometabolism. So red is deficit. So the area in red are deficit. So are hypometabolic. So as compared to the locked-in patient and the patient who recovered after a disorder of consciousness. There is not only the resting state that you have to take in account. You can also, I wanted also to underline that patient in locked-in syndrome in the acute phase. So usually when you scan a patient in a locked-in syndrome, you will have no supratentorial deficit. You will have only deficit in an hypometabolic activity in the cerebellum, which is simply linked to the motor dysfunction. But in the acute phase, you will also observe higher metabolism, and hypermetabolism in the amygdala, which is just related to anxiety and negative feeling. You can imagine that in the acute stage, when you wake up and you cannot speak, you cannot move, it generates a lot of anxiety. So usually what we advise is to monitor this patient at an anxiety level, so giving anxiety treatment. Now you can also present some stimulation for seeing what's happening in vegetative versus minimally conscious patient. And for instance, the more recent data that we have is the nociceptive perception. I mean, these data are not so recent. The slide after is more recent. So here, what you can see is it was a thermic pain, so they just applied some thermic stimulation to the medial nerve of control and vegetative patient. And what they observed that for, you see here the activity in red, and you see here that the same area are in hypometabolism. So the area coding for pain are in low level in vegetative patient as compared to control. The only one which was activated was the somatosensory cortical area, and the primary one, not the associative area. So it was quite different when we recently assessed pain in the same way in minimally conscious patient. We were not able to see a significant difference between the controls and the MCS patient, meaning that in vegetative state, maybe there is a real deficit in the treatment of stimulation. We showed exactly the same for auditory perception. So when we just presented a tone to vegetative patient, there were only an activation of primary cortex area and not associative cortex. It was the contrary in the minimally conscious states. They were able to activate a lot of different associative cortex, underlying that the patient minimally conscious state can really treat the information maybe in a more integrated level than the vegetative patient. And be careful, I don't say that vegetative patients don't feel pain, right? I don't want everybody to think that. It's just that the result means that there is a really deficit in the perception of this patient. Another thing which is really important to know is that this patient, the vegetative patient versus the minimally conscious patient, have a different kind of functioning. We try to assess the functional connectivity between different areas, which mean a kind of communication through the brain, and it's very important when you treat an information, then all these areas communicate with each other. So we we showed what? We showed that vegetative patients don't show really a correlation between thalamocortical area, but also cortical area, and so bring the fact again that the vegetative patient could really not perform a processing in an integrated level as compared to the minimally conscious stage, which had a really good functional connectivity. So there is the red line, which are the vegetative states, and the green line is the minimally conscious state. So basically it's the correlation between the primary somatosensory cortex and the parietal cortex. And you see the positive correlation between both area for the minimally conscious states, and the quasi absence of correlation between these both area for the vegetative states. Now, there is not only, so I talked about the fact that you can just take the resting state, you can present stimuli, but all these stimuli don't have the same valence. Some stimuli are more powerful than others. And for instance, we compared its MCS patient. We used a tone, baby cries, and our name, the our name of the patient, the first name of the patient, and we presented this stimulation to this minimally conscious state. And you see the huge difference that there is between the tone, which only activates the primary auditory cortex, as compared to the large temporal activation following the baby cries, and the more area involved in following the whole name. So the whole name seemed to be very interesting to use because it was a very powerful stimulation. So we decided to simultaneously to record the ERP in this patient following the presentation of his whole name. And we presented 7 unfamiliar names, and among these names there were his first name. And we saw what? We saw that there were in fact a response, a higher response here following the presentation of his whole name as compared to other unfamiliar name, which means that he was able to discriminate his whole name. So we thought maybe it's a good idea to use it for detecting signs of consciousness. So maybe we have to use it in vegetative, minimally conscious, and Elkins syndrome patients. So we made a study with 5 control, 4 locked-in syndrome, 5 vegetative patients, and 6 minimally conscious patients. And we use the same paradigms, that is, representation of unfamiliar name, versus the own name of the patient. And, you know, as compared to controls, we observed a larger response to the first name for the minimally conscious patient, but also for the locked-in patient. But the problem was that we observed this response also in 3 out of 5 patients in vegetative states. So we saw this is a big deal because these patients are think to be, you know, are diagnosed as being in a vegetative state. They don't have, for the most part, a good outcome. So how can they do that? Happily, in the same time, other study was published showing that you can process your first name and detecting your first name under anesthesia, but also in your sleep. So the brain is able to treat information maybe more complex that we could think before. So we think, okay, maybe it's not a good paradigm. Maybe we have to use active paradigm. And Melanie Boley developed a paradigm which was used in a study by Owen and co-worker maybe you know them. It's the Cambridge staff in UK, and they just asked a patient to imagine playing tennis, and they compared this activity to a control subject, and they found in a patient diagnosed as being in a vegetative state, they showed a quite similar activity as compared to control. Now the thing is that there were a lot of debate on the real state of this patient, because there is a lot of debates about the diagnosis criteria. You know surely that. So for instance, the visual fixation is considered by UK as a signs of unconsciousness, and by the Aspen War Group, USA, as a signs of consciousness. So it's maybe just mean that visual fixation is a sign of consciousness, and this patient therefore was not in a vegetative state, but was in a minimally conscious state. So anyway, it was an interesting thing, and we wanted to use it in more patients. So it's a study that this study is in press, or is maybe published now, that I didn't receive the proof, in Neuroscience, because we met a very interesting case of a patient in a total locked-in syndrome. I don't know if you are familiar with the different category in the locked-in syndrome, but you can have a patient who just move the eyes, so the classical locked-in syndrome, the incomplete locked-in syndrome, where you can move maybe the finger on or the head, or the complete locked-in syndrome, which is the patient cannot move their eyes, they cannot move anything. So it's quite impossible behaviorally to say that this patient is conscious. At a behavioral level, it's impossible. So we met a young girl who was, for me, I saw her and I said, she's in a coma, she's not conscious for me. And as she had a basilar thrombosis, we wanted to make a PET scan to be sure that there were no possibility for maybe a locked-in syndrome. And I show you the activity, the typical activity of this patient, and it was exactly that. So there was a preservation of the brain activity, there were no supratentorial deficit, but there were an hypometabolism in the cerebellum. So we said, okay, so this patient is maybe in fact in a locked-in syndrome. So we said, okay, how can we deal with that? Maybe we have to use the active ERP for her to know that maybe we know that she is conscious, and maybe to interact with her. So what we found, so I will maybe explain this paradigm. So for the control subject, you see already the response. So there were two conditions. The first was we asked the patient for counting his own name. And the other was they had to count another unfamiliar name. For the first condition, you see in blue the non-target. So the target where they listen to, but they have nothing to do with that. Just listen. You see in green the passive response to the familiar name, so to the first name. So you see that there is a response, which is completely normal, as it's the first name of the patient. And now in red here, you see a higher amplitude of a response when when you ask them to count the stimulation. This is only for control, but it's just for explaining how it works. And we did the same for the other condition. You see in blue, non-target, in green, the response to the unfamiliar name, and there is nothing because it's the unfamiliar name, it's not the first name of the patient. And you see a higher amplitude when the control is actively doing something. And what we obtain is in the total locked-in syndrome, in this syndrome, in this patient, sorry, we obtained for one condition, for the condition where the patient had to count his whole name, a larger response when this patient had to count his first name, her first name, as compared to only listening to in green. So it was very important to show that she was able to do it. So now, it's true also that you see that there is no response in the second condition. And in fact, in the beginning, you could say, maybe she was tired. I mean, it's a lot of condition. Maybe she was just tired, but it was not the case because it was the first condition presented. So this means that maybe there were a fluctuance of vigilance, which means what? That this patient, locked-in patient, was maybe in minimally conscious state when I assessed her at that moment. And it's not impossible. You can have a locked-in syndrome, being tetraplegic, and having some recovery of consciousness. And I say that because we have, I will show just after, some data supporting that. So we decided to use this paradigm in more patients. And so you see the same in more control subjects. We assess vegetative patient. We show nothing. There were nothing according. We used the Aspen Work Group criteria. We showed nothing in this patient. But for minimally conscious states, it was quite different. We obtained a larger response when this patient had to actively do something. In red, you see that, as compared to the passive condition when they have to do nothing, meaning that they were able to respond to the command. Now you could tell me, yeah, but this patient were, I suppose, all responding to command. No, it's not true. They were low behavioral response. So there were patients only showing visual fixation or visual pursuit who respond to one of the commands. So it was really interesting to show that, and maybe it's underlined the fact that we could, in the following years, better understand the preserved cognitive component in this patient using active ERP paradigm. First, it's not impossible, and second, there is something there, and we have to know exactly what is preserved in this patient. And this study was published in Neurology recently. And last one is just to say that, as you know, there is some study which try also, there is a lot of study on diagnosis, but there is some try now to do study about treatment. And so we did a study on a patient receiving Amantadine with ABAB paradigm, which means that there were a baseline, 2 periods of treatment, and 1 period where there were no treatment, just for seeing the fluctuation of brain and behavioral behaviors according to the presence or the absence of treatment. And after 2 weeks of receiving, so this patient was a chronic anoxic patient, chronic 2 years. This patient was only able to show inconsistent visual pursuit according to the CRSR. I made the CRSR during 6 weeks, 1 time a week for the baseline. And after we administered treatment during 6 weeks, and I made the CRSR during 6 weeks also. And I saw after 2 weeks that the patient was able to respond to command. At 5 weeks, we made every time, so for the baseline, we made a PET scan, and for the Amantadine, we made a PET scan again. For each phase, we made a PET scan, and we showed that according to the presence or the absence of treatment, there is a fluctuation of brain area. And more exactly, after the first treatment period, there were the recovery, you observe the recovery of frontotemporal parietal areas in this patient. And when we had Amantadine, so he recovered these areas. When we stopped Amantadine, we observe a decrease in this area, not so, it was not so low than before treatment, but there were a decrease, and when we just gave again the amantadine, the brain activity in this area increased again. So it's only one patient, that's true, but there were a study that Dr. White made on this treatment and showed that there were a lot of patients who were responding to this treatment. And it's just for underlying the fact that now we maybe have to validate more treatment for this patient for giving them a better quality of life and a better recovery. So, thank you very much.